It is it's with great pleasure that I welcome all of you to this special webinar, and which Dr. Rob Peters has kindly agreed to speak to the Indian community of pediatric hematologists, oncologists. We are really privileged. I would request Dr. Banavli to please formally welcome him and just say a few words about the Childhood Cancer Awareness Month. Say you're mute. Say you're mute. Can you unmute?
Yeah. Thank you, Manas, and thank you, everyone. Good afternoon, everyone. And first of all, thank you, Dr. Rao Peters, for taking out time and joining us in this meeting. As we all know, nothing new to the community that is there. So, on behalf of the Indian Pediatric Hemato-Oncology Society, I welcome you all for this webinar, which we have been doing since the start of the term that was there. So we always did the webinars for basically in this field, but since last 2 years we have been doing this webinar with international speakers once a month, so that basically we have exposure to international people also, and great people like Dr. Rob Peter. We get to hear their experiences also. So most importantly, this month being the pediatric cancer awareness month, we take this opportunity to create the awareness about pediatric cancer and the need that is there, to come together and work together in this field so that we can help improve the outcomes of children with cancer, not only in India, but through our united efforts. We try to help to improve the outcomes of children with cancer, childhood cancer, especially in countries where it's required. And we are working in that respect, even with the WHO and the St. Jude Alliance. So basically, it's a great opportunity to be at the right place at the right time. And again, this webinars have been well received over the last 2 years. And I think this Dr. Manas, I take this opportunity to thank Dr. Manas also, because he's really being this general secretary. I think he's really working hard for all doing this. The 12 mahine, 12 posters. That's another thing that he's really working hard on. So I think it's overall helping us create more awareness in this field, and that is required because there's a lot of now not only infrastructure, trained manpower available in the countries, but lot of government schemes, lot of CSR funding through which we can make sure that we can take care of all the children diagnosed with cancer in the country, irrespective of their financial abilities or irrespective of whether they have their insurances or not. So I think we are at the right place at the right time, and it has really helped us treat many, many more children with cancer as compared to some years back. And overall, I'm sure if you do the analysis, the outcomes of children with cancer must also have improved in the last few years because of all this initiative. So over to you, Dr. Once again, Dr. Rob Peter, thank you for being there, and I'll request Dr. Manas Karla to introduce you formally. And we have been working with or hearing Dr. Rob Peters in many of the SIAP meetings over the years, but it's good to have you exclusively for the Indian crowd here. And we hope that you do attend our meeting here in person sometime. We'll like to invite you for that also, and experience our Indian hospitality in the near future. Thank you, sir,
He,
and over to you,
he
Manas.
has been busy, and he has been declining our invitation, but I'm sure we will get his attention very soon. Thank you, Dr. Rob Peters, for being here with us. He's full professor in pediatric oncology at the University of Utrecht. He's initiator and one of the founders of the Princess Maxima Center for Pediatric Oncology, the largest center in Europe for treatment and research of childhood cancer. He was chief medical officer and co-CEO of the Princess Maxima Center from 2013 to 2025. Since January 1, he is Chief Maxima International and part of the executive committee of the Princess Maxima Center. He is president-elect of SIOP, member of the European Cancer Mission Board, and editor-in-chief of the Journal Cancer. His focuses on the personalized therapies for childhood ALL and has published more than 700 peer-reviewed scientific papers and given more than 400 invited lectures and has supervised more than 65 PhD students. In 2018, he received a Royal Knighthood decoration as Officer in the Order of Orange Nassau for his achievements for childhood cancer. So over to you, Dr. Rob. We are really waiting to listen to you about what is happening in the field of childhood acute lymphoblastic leukemia, especially the perspective of Netherlands.
Thank you. Thank you very much. And I'm sorry that I had to decline the invitation to come in person to India earlier, but my schedule didn't allow me so. But I'm happy to have accepted this invitation to give the talk. I will try to share my screen. Yes, 1 second. Let me see. It's here.
Yes, sir.
Yes, you see it. Yeah. So,
Yeah, perfect.
Okay, you can see it. Yeah, fine. Let me do one thing here. Yes. So I will share with you the results from our recent translational and clinical studies in the last, let's say, 10, 15 years. Part of these data, at least, that we did in the Netherlands and especially in the Princess Maxima Center. So I have different topics. I would like to talk on infants, on the BCR-ABL-like ALL, on our studies on asparaginase, the results of our ALL 10 and 11, and the ongoing altogether study. And I will finish with a few data that we ourselves have on immunotherapies. So as we all know, the genetic abnormalities in ALL differ highly by age, which you can see here, the children, so child standard risk, high risk, the young adults and older adolescents, and the adult population. This comes from a review that I wrote together with Charles Mulliken and Steve Hunger. These are the abnormalities. Well, it's just to give you an impression, so you don't have to learn this by heart. But you see what is most important, that the distribution of these abnormalities are very, very different between the different age groups and also between standard risk and high risk patients at childhood. So one of the most interesting, perhaps, genetic abnormalities is the KMT2A gene, which is rearranged in about 3/4 of infants, and above the age of 1, it's only 1 to 2% rearranged. And this is an older slide that's showing that the KMT2A rearranged infants have a much worse outcome than the KMT2A germline cases. These were data from our Intervent 99 study. Within the KMT2A rearranged cases, you can discriminate between two groups. Groups that have other high-risk features, like a very young age, below the age of 6 months, and a very high cell count or presence on poor response. And if you have in total 3 of these high-risk features, you have a much worse outcome than if you have only the KMT2 rearrangement. So it's not only the KMT2A, but also a younger age and a very high tumor load or a poor response to prednisone that depicts your final event-free survival. What we did in the Intervent 06, and there are some interesting data from that, is we randomized the consolidation course 1B versus 2 myeloid chemotherapy courses. Why did we do this? Because in infants, the KMT2A rearrangement occurs in a very, very immature cells that has a lot of myeloid characteristics. It is a lymphatic progenitor, but with a lot of myeloid features. And because these myeloid features, we thought, well, perhaps it's a good idea to, instead of the classic protocol 1B, so the first consolidation course, give 2 intensive myeloid chemotherapy courses. And when we looked at the results, it first looked at giving these myeloid courses would improve the disease-free survival, but with the longer follow-up, we see that curves come together, and at the predefined endpoint of 3-year disease-free survival, although there was a difference in this 45% versus 38% for the myeloid courses versus protocol 1B, this difference was not significant. So you may conclude it doesn't make sense to give the very intensive myeloid chemotherapy courses instead of the classic 1B there. However, when we look more carefully into these data, a very, very interesting finding came up. So these curves are for patients that were negative, had a negative MRD at the end of induction. These are the curves for patients that have a high MRD at the end of induction. Let's first look to the left side of the slide. So patients that responded very well to the induction chemotherapy and thereafter were treated with protocol 1B had a much better outcome than the patients who were thereafter treated with the myeloid chemotherapy course. So in other words, if you respond very well to the induction therapy, you benefit from using protocol 1B instead of the myeloid blocks thereafter. But if you responded poorly to the induction chemotherapy, so still a high MRD, it was the opposite. Actually, if you were then treated with 1B, the outcome was much worse than when you were treated with the myeloid chemotherapy courses. So this means that the induction therapy selects the patients that benefit from myeloid chemotherapy courses, and it selects the patients that benefit from 1B. So the infant ALL population with the KMT2 rearrangement seems to exist of two different subpopulations, and the ones responding well and thereafter benefiting from ALL consolidation, the ones responding poorly to the end of induction, and they are benefiting from myeloid consolidation chemotherapy courses, and this is currently used in the new interval protocol. Another important finding is when we added blinatumomab to the chemotherapy. So what we did, we used the full Interfund 06 chemotherapy protocol and just used one course of blinatumomab after the induction before protocol 1B. So it was 28 days. It was like we always do, 4-week continuous infusion. And at day 15, we gave intrathecal prophylaxis. And the results were very surprising. There were only 30 infants treated with this, with the addition of blinatumomab. It was a pilot study, but what can clearly be seen, the disease-free survival went up from 50% to 80%, and the overall survival from 65 to 90%. So a clear benefit by adding blinatumomab on top of Interfund 06. But be aware, it's a pilot study, only 30 patients. Now we have a much longer follow-up time, and I can tell you that we did not publish this yet, but with the longer follow-up time, the data holds true also on the long term. The patient that relapsed, there were 4 out of 30 patients that relapsed, 2 isolated CNS relapses and 2 combined bone marrow and CNS relapses. So be aware that blinatumomab is not covering the central nervous system very well. The BCR-like group. We all know the translocation between the BCR gene and the ABL gene that leads to the BCR-ABL fusion, and which plays an important role in ALL and also in CML. And if you use imatinib or other tyrosine kinase inhibitors, imatinib and these other kinase inhibitors bind at the place where ATP is used by this tyrosine kinase. And if you block this with these drugs, ALL stops dividing. 2 important studies, one from Europe, one from the US, both showing that addition of imatinib on top of chemotherapy improved the outcome. This was a randomized study, and this is a study compared to historical control. Of course, you can argue that the historical control in the CUG was very low, and therefore the difference is very big. but both curves, both this one and this one, let's say chemotherapy, and on top of that, imatinib, they end up with 70 to 80% disease-free survival in the Philadelphia positive ALL group. Also, it showed that you don't need, you don't need transplant in these patients, and probably only less than 10% of Philadelphia positive ALL patients need a transplant upfront if you give them imatinib on top of their chemotherapy. In 2009, we discovered, and actually Monique Den Boer, one of our principal investigators, discovered the BCR-ABL-like subtype. In those days, we did gene expression profiling, and every row here, every individual row is one patient, every column is one gene. And what you see, and what was not surprising, that patients with the same type of ALL, like the T-cell ALL or the E2A rearranged ALL or the MLL rearranged ALL or the TEL-AML rearranged ALL, each genetic subtype has its own gene expression profile. Well, that was not so surprising. What was surprising were these empty spots in which we didn't know the classifying genetic abnormality. Here is a group, here is a group, and here's a group. And these two groups surrounded the BCR-ABL cases, and they have the same gene expression profile. So therefore, we called these BCR-ABL-like ALLs. When we look to the survival rate or disease-free survival, I must say these BCR-ABL-like cases had the same poor outcome as the BCR-ABL positive cases, both in a Dutch cohort and in a German cohort. Of course, the question was thereafter, what genetic abnormalities do these cases have, and can we target these also with tyrosine kinase inhibitors? Well, unfortunately, from all the BCR-ABL-like ALL cases, only 12% have an ABL class mutation. So it's with ABL1 or ABL2, with PDGFRB fusions or CSF1R fusions. Together, they form only 12% of all BCR-ABL-like ALL cases. But these cases are targetable with tyrosine kinase. There's another class of patients that belong to this group, the patients with JAK STAT abnormalities. Perhaps you can target these with ruxolitinib, although there are no clear data that support the use of these drugs in these patients. So what we did is the next study, we call this the Ponti-Legno study, in which many study groups from all over the world donated, in fact, their data from 122 cases with an ABL class abnormality. So these are the 4 subclasses involved. So be aware, you have the BCR-ABL cases. Part of them have an ABL class abnormality, and these we focused on because you can target these cases. The frequency was as follows: half of all cases had a PDGFRB, and the other half had a mix of these cases. And what we saw, and look at the right side, that in these 122 cases, before we used tyrosine kinase inhibitors in these type of patients, there's roughly a 30 to 40% relapse rate, which is much higher than in other types of leukemia. So this confirms the poor outcome. And what we next did was looking to which tyrosine kinase inhibitors these subtypes were sensitive, and we discovered an important findings was if you transfect cells with these genetic abnormalities, so ABL2, ABL1, CSF1R, or PDGFRB, you see that actually this is the IC50, and the IC50 for imatinib for the PDGFRB is extremely low. In other words, PDGFRB translocated cases are very, very sensitive to imatinib, but they are not sensitive to dasatinib. In the new upcoming protocol, which COG and the Altogether study group and the ALBFM study group will use in children with Philadelphia positive ALL and ABL class cases, We will use dasatinib for all these subtypes, but not for PGFRB. There we will use imatinib. All these, and this protocol includes blinatumomab for everybody and a tyrosine kinase inhibitor for everybody, but the type of kinase inhibitor differs according to the subtype. These are the preliminary results, but very important results for these PGFRB rearranged cases. So these are half of all the ABL class cases. Before we use the tyrosine kinase inhibitor, the MRD at the end of consolidation was very high for the far majority of cases, so above 0.1%. When we added imatinib at day 15, so these children after day 15 received 15 days of imatinib during induction, and then during the consolidation phase, another month of imatinib, 9 out of 10 were MRD negative after this. So it shows that adding the imatinib significantly reduces the MRD, and all these cases were eligible for transplant because of their high MRD. Now none of them is anymore eligible for stem cell transplant. So this was a very, very important finding. Switching to our asparaginase studies. A study that I more or less forgot and I reintroduced it in my talks on asparaginase was a clinical study that we did in newly diagnosed pediatric ALL patients. We gave them 1 dose of PEG asparaginase, Oncaspar. We called at the start of the treatment. This was called day -5. Then we measured the response to PEG asparaginase, and at day 0, we started combination chemotherapy. So it was a window of only 1 dose of PEG asparaginase in newly diagnosed ALL cases. And you see, this is a log scale. The leukocyte count dropped significantly from 50 to, let's say, 0.5 percent. So this is a 2 log decrease, which means that 99% of leukemic cells were killed by only 1 dose of PEG asparaginase, showing the potency of this drug. All these light gray lines are individual patients, and you see that not all patients respond to PEG asparaginase. There are a few patients that did not see any reduction in the leukemic load, but the majority did. These are data from a COG study that I will use to illustrate my next point. If patients receive their planned pegylated asparaginase dose, they have a better outcome than patients in which the dose was not given according to the protocol. This is called so-called truncation of the PEG asparaginase. Most often, these patients missed asparaginase because they showed an allergic reaction, but there are also patients that had a silent inactivation of PEG asparaginase here, in which the PEG asparaginase was not replaced by Erwinia. If PEG asparaginase could not be given according to the protocol and was replaced by Erwinia asparaginase, the outcome is again 10% higher than in those patients that did not fulfill their full asparaginase course. In other words, if you can't give Oncaspar or pegylated asparaginase according to the protocol, it has to be replaced by Erwinia asparaginase to maintain the very good outcome. Of course, everything depends on the availability of the drugs. The same was found by the Scandinavian group. These are data from the COG. This is from the Novo group. And here they show the relapse rate, which is twice as high for those cases that could not give asparaginase according to the protocol. And these are the patients that received asparaginase according to the protocol. So the most common cause of not being able to give PEG asparaginase according to the protocol are allergic reactions. And the overall incidence of allergic reactions in these 7 study groups, and we studied almost 6,000 patients, the prevalence of the allergic reactions is roughly 10%. And this means this 10% of these patients inactivate by these allergic reactions their oncospar. So you need to replace these patients by uremia. There are also allergic-like reactions. So you have these atypical allergy reactions. So you see mild reactions to asparaginase. And if you then measure asparaginase activity, it's not always inactivated. And this is by definition called atypical allergy or allergic-like reactions. So you have some allergic reactions, but you do not inactivate the drug. And these patients can simply continue with the drug they are on. We've published some consensus and a recommendation on how to identify and manage asparaginase hypersensitivity and silent inactivation. And basically, the data are summarized on this slide. If you have a real clinical allergy, you have allergic symptoms, and in all these patients with real allergies or anaphylactic reactions, all these patients inactivate their asparaginase because of the antibody causing the allergic symptoms. These patients, you have to switch to uremia asparaginase if it is available. You have patients with allergy-like reactions. They have allergic symptoms, but if you measure the asparaginase activity is actually quite good. So you simply can continue with the asparaginase preparation they were on. The most dangerous group is the last group. These are the silent inactivators. You have no allergic symptoms, and if you measure the asparaginase activity, they don't have asparaginase activity. In fact, the drug is inactive. Well, if you don't measure the drug activity, you will miss these because these patients have no allergic symptoms. Also, these patients, because they have no active asparaginase, should be switched to uremia asparaginase. This group and this group together is in most protocols 10%, but in some protocols at the moment is 20 to 25%, and we don't understand why this is. So what determines the allergic reaction to asparaginase? There's actually only one factor, that is the number of PEG asparaginase-free intervals. Because then during this asparaginase-free interval, the antibodies rise, and then if you then give again asparaginase, then you get your allergic reactions and your inactivation. This is by far the most important determinant of allergic reactions. Not the number of doses, not the dose itself, it's the number of asparaginase-free intervals. And most groups are used to give asparaginase as follows. You give it in the induction, and it can be 1 dose or 2 doses or 3 doses. Then you have consolidation without asparaginase, and then during the intensification, again, you give back asparaginase. So this is an asparaginase-free interval. So we said, is this a smart schedule? Why don't we give this back asparaginase earlier so that we have a continuous schedule? And we decided to randomize this. The classic non-continuous way versus the experimental continuous way. The total amount of asparaginase was the same. It was just giving it earlier than we were used to. And these are the results. In total, the allergic reactions were 10% in the discontinuous group and only 2% in the continuous asparaginase group. Or when we looked only to the real inactivating hypersensitive reactions, it dropped from 8% to 1%. So if you give asparaginase in a continuous way without asparaginase-free intervals, the incidence of allergic reactions is very, very, very low. The toxicity, let me say this because I don't have a slide, the toxicity between the two arms, non-continuous versus continuous, were the same. The only thing what was different that you saw your toxicity earlier when you gave a continuous regimen, which is logic because there you give your asparaginase. But overall, the toxicity was the same. Here you see it later, and then you see it earlier. There may be another reason why we should measure asparaginase activity, and this is toxicity. There are some data showing that the asparaginase activity level, which is here shown on the horizontal axis, is related to the incidence of pancreatitis and osteonecrosis, not for thrombosis. I must say the evidence is not very strong, but there may be some relation there. So we looked for, can we not lower the dose? Because it may reduce toxicity, and it's definitely much cheaper to lower the dose because you can use the same vial for more patients if you reduce the dose per patient. So what we did was the following. The first 3 doses of PEG asparaginase we gave in our protocol was a fixed dose, 1500 units per square meter. Thereafter, we lowered the dose every time and every time and every time, by which we measured the asparaginase activity. And we said the lower threshold is 100 units per liter, which is absolutely sufficient to completely deplete the serum from asparagine. Actually, 50 units per liter is also enough, and probably even 20 is enough. But we said, okay, let's stay on the safe side. We want to have the asparaginase activity between 100 and 250. So we measured continuously the asparaginase activity. And if the dose level was above 250, we reduced the dose. If the dose was below 100, we would have increased the dose, but this never happened. And what you see is that we can slightly reduce the dose from 1500 units per square meter to 400 or 500 units per square meter. Let's say 500. Remaining in the safe area that you have sufficient asparaginase activity levels. So it is much cheaper to use 500 instead of 1500, or in other words, you can use 3 patients instead of 1 patient with the same file. And some schedules, or many schedules, use 2500, which means you can treat 5 patients instead of 1 patient with the same file. DCG ALL10 studies. The very classic slide that MRD, everybody knows this. If you have a low MRD at the end of induction, you have a much better outcome than a high MRD at the end of induction, and you have an intermediate MRD level, you have an intermediate outcome. That is basic knowledge of all of us now. What we did in the ALL10 study, we acted on this. This was the first study that acted on the MRD levels. We started this in 2004 and ended the study in 2012. For those patients, 25% of patients that were MRD negative at the end of protocol 1A, so at the end of induction. If you were MRD negative by PCR, 25% of all patients, we reduced protocol 2 to protocol 4. I will show you in a few slides later what this reduction meant. It's a significant reduction in chemotherapy. For the medium risk patient, we intensified protocol 2 with a lot of asparaginase in it, according to the Dana-Farber schedule. And for the small group of high-risk patients, it's only 5%, we gave very intensive chemotherapy blocks plus stem cell transplant. And what we saw was that the therapy reduction in the standard risk patients is safe because the 5-year survival, shown on this slide, is 99% with the therapy reduction. So it's very safe to reduce the therapy for the 25% of patients that is MRD negative at the end of induction. The intensification with mainly more asparaginase led to an increase of EFS from 76 to 88%, and the very, very intensive chemotherapy for high-risk patients also had a big benefit. In other words, adaptation by MRD is a big benefit for patients because in some you can reduce and in others you can increase the therapy with a better outcome. How did we reduce the therapy in the MRD negative patients? We reduced it further than the AO-BFM group did. What the BFM group did, they skipped from this classic protocol 2, they skipped 1 week of dexamethasone and 50% of vincristine and doxorubicin. And this was called protocol 3 compared to protocol 2. We said now we will use protocol 4. We skip all the anthracyclines and we skip the full second phase. So no cyclophosphamide, no AOC, no 16G here. So we went further than that, and actually our intensification protocol was only 2 weeks of dexamethasone and tapering, 2 doses of vincristine, and 1 dose of PEG asparaginase, and this was the intensification. And if you look then to the 5-year cumulative incidence of relapse, it was with the classic protocol 2, it was 4%. With the protocol 3, the way the German Italians did, it was 8% 5-year cumulative incidence of relapse, and with protocol 4, 6%. If you look to the 8-year overall survival, it was 98, 96, and 97%. So actually the outcome is the same. So we think that you should reduce the intensification phase for these MRD negative patients really seriously by protocol 4, which may lead to a few more relapses compared to the classic protocol 2, but these relapses can be rescued by relapse therapy. Look at the 8-year survival rate. The alternative is that you don't reduce, you give everybody protocol 2, but then everybody suffers from the extra toxicity, but you have less relapses. So this is a choice that every study group can make themselves. The ALL-11 study, we further specified things, and we saw that in the medium risk group, the presence of ICOS deletions led to a worse outcome of 3-fold increase in relapse rate. This is by far the largest group. This is 75% of all patients, or 70% of all patients. This is 25% of all patients. This is 5%. So we said, well, if these patients with an ICOS deletion have a worse outcome, and most relapses occur in the year after the stop of therapy, so between the 2nd and the 3rd, 4th year, we said, why don't we simply increase the length of the therapy for these patients, so 3 years instead of 2 years. For other subclasses, ETV6 ranks 1, they had a 99% survival at 5 years on the ALL-10. We said, well, then we can reduce the therapy and we delete the anthracyclines. The Down syndrome cases had a very high toxic death rate, so we deleted all anthracyclines there. And the prednisone pool responders were treated as high-risk patients. And we said, well, with the MRD data we have, it's not necessary to use the prednisone response anymore. We simply treat, if you have only prednisone pool response but a good MRD, you can treat them according to medium risk protocols. So this was how it looked like. The medium risk group, if you had an ICOS deletion, you get the 3rd year of maintenance. And for the ETV6 ranks 1, the anthracycline was skipped here. For the Down syndrome patients, the anthracyclines were skipped here, and also in the induction, the anthracyclines were skipped. This was the overall outcome, an overall survival of 94%, shown here at 5 years, event-free survival 89%, and a cumulative incidence of relapse of 8%. So 94% survival, 89% event-free survival, 8% relapse rate. Cumulative incidence of death was 3%, death due to toxicity. And what were the results of prolonging the therapy for the ICOS deleted cases from 2 years to 3 years? A significant improvement in event-free survival from 74% to 91%, and the relapse rate reduced from 25% to 8%. So, although we say everybody needs 2 years of treatment, it may be that ICOS deleted cases benefit from a 3rd year as shown here, but this data has to be confirmed by others. The anthracyclines can be safely skipped for the ETV6 ranks 1 cases, because the outcome was at least as good as with anthracyclines compared to without anthracyclines. See here the relapse risk. The blue line is for those patients treated without anthracyclines, and the relapse risk is almost 0. So you can safely reduce therapy for these ETV6 ranks 1 translocated cases by skipping the anthracyclines. So the overall outcome from ALL-1 in the early 70s to ALL-11 went up from a few percent to 94%. And this includes all ALL patients in the Netherlands, also the patients that were not eligible. So it was really a population-based comparison what I showed you here. The Altogether study, what do we do now? Well, the Altogether study actually started with a discussion between Nick Golden from the UK group, Kjeld Smigelo from the Nordic group and myself from the Dutch Child Oncology group, and we all said our protocol is the best. But until we said, well, let's share the data and plot curves of this. Well, if you can see the difference between these curves, you have a special gift because the curves are identical. And also for the German COBALT study group, the curves were identical. So we said, well, if we have identical curves with different protocols, why don't we join? And this led to the Altogether study group. So the Altogether study group now includes 16 countries, all Scandinavian countries, the Baltic states, the UK, the Netherlands, Belgium, France, Spain, Portugal, Cyprus, and part of Germany. So we recruit about 1,500 cases per year in this age group. Most of the patients are below 18, but a few groups also include young adults. We use genetics, molecular genetics, and MRD for risk group stratification, and I will show you how. These are the classic genetic abnormalities that we know. The good risks one, the hyperdiploids, the high hyperdiploids, the ETV6 rank 1, they have a good outcome. The poor outcome are BCR-ABL, KMT2A, TCF3, HLF, amplification, interchromosomal amplification of chromosome 21, and the low hyperdiploids. And you see that the genetic good risk patients have a better outcome than the genetic poor risk group patients. This is classic knowledge. But we also looked at copy number alteration in 8 different genes measured by an MLPA. Well, you can look at here, but I always have to look back to my own slide, how it exactly is. Poor risk patients by copy number alteration are the ones who have an isolated deletion of Icarus, PAR1 or RBM1, or a deletion of these two together. You have good risk, copy number alteration, and intermediate risk, which are all others. And you see in 2 big studies, one from the UK and one from a much bigger group, including more than 3,000 patients, we see that it can be confirmed, the data found earlier in the UK as by the Dutch and other people. So this classifier is also used now in the Altogether. And then the third value, the MRD. And what is interesting is if you measure the MRD at a certain time point, let's say the end of induction, then of course MRD is of prognostic relevance, but the exact predictive value of relapse differs for the same MRD value by genetic subtype. Let me take, so the darker the color, the higher the increase, the higher the relapse rate. From the very light color, it's only 1% relapse risk, very dark is 45% of relapse risk. Take as an example, MRD end of induction of 0.01%. Well, for the ETV6 ranks 1 case, it means a relatively higher risk of relapse, but in absolute sense, not that big. The same MRD value at the end of induction. For cytogenetic high groups, or T-cell ALLs, they predict a much higher relapse risk there. So it's not the exact MRD value that depicts the outcome. The MRD value predicts the poor outcome, but the exact prediction depends on the genetic subtype. This knowledge of classic genetic abnormalities on the copy number alteration profile and the MRD is used now in the Altogether. The schedule looks difficult, but it's not. I will show you. We start all patients with a 3-drug or a 4-drug by NCI criteria, such as NCI standard risk or NCI high risk. Then we measure the end of induction MRD and we discriminate 3 groups, like we always did. MRD negative, standard risk. Very high MRD, below 5%, so you're not in remission then, high risk. And a big group in the middle, 70% of all patients. And this intermediate group is split up in 2 groups, intermediate risk low and intermediate risk high, depending on the interplay of the genetic abnormality and the MRD load. Don't try to remember this, nobody can. but in fact we have 4 risk groups: standard risk, high risk, intermediate risk low, and intermediate risk high. The able class fusion gets specific therapy. They get intermediate risk high therapy plus imatinib on top of it. And for the Down syndromes, we give blinatumomab instead of several intensive chemotherapy courses. And if you simplify the schedule, it looks like this. The standard risk and the intermediate risk low together, this is 60% of all patients. They have a 5 years overall survival rate of 98-99%, and a relapse rate of 4%. So these are the patients that we are reducing the therapy by skipping the doxorubicin and skipping the pulses. We study this in a randomized way at the moment. 60% of patients, extremely good outcome. So opportunity to reduce therapy. Intermediate risk high patients, which is 1/3 of patients, have only 89% overall survival, a 15% relapse risk. There we intensify the therapy by inotuzumab or by intensification of the maintenance therapy with 6TG on top of 6MP and MTX. 15% relapse risk, and the very high risk patients have also 15% relapse risk, but with very, very aggressive therapy, so the high-risk chemotherapy courses and stem cell transplant. These patients, if they are B-ALL, we give them CAR T cells instead of the intensive chemotherapy courses and bone marrow transplant. The T lineage get nelarabine on top of the chemotherapy. Finally, if I still have time, I will show you a few data on immunotherapies. I will go very rapidly through this and then I will finish. So in our review in 2023 in Journal of Clinical Oncology, we listed the precision medicine strategies that you can use nowadays or the immune therapies. One thing, of course, what is of high importance are the blinatumomab data, in which 2 randomized studies in relapsed ALL, USA study and European study, both show that addition of replacement of intensive chemotherapy by blinatumomab improves outcome in relapsed ALL. 3 studies in upfront newly diagnosed patients show also benefit of blinatumomab. Our own study on infants, I just showed you. The standard risk B-cell ALLs, the COG, improvement by adding blinatumomab to the chemotherapy. This was an addition of blinatumomab to the chemotherapy. And in adults, it's a randomized study in which blinatumomab on top of chemotherapy led to a much better outcome. So 3 upfront ALL studies showing that blinatumomab adds to the survival rate. What we also did was phase 1-2 studies on inotuzumab. Now we're doing the phase 3 studies, and actually inotuzumab in relapsed ALL has a very low toxicity, and it's very effective. Probably, or not probably, if you look at the data, at least as effective as blinatumomab on full-blown leukemias at relapse. These are data from the phase 1 study. We also studied whether the pharmacokinetics are different in pediatric patients compared to adult patients, and the answer is it's not different. So the PK is exactly the same in children as in adults, and we published this last year. CAR T cells, I don't have to explain you the principle behind this. What is important is a study that we did with the lymphodepleting regimen that you give before you give CAR T cells. So you try to deplete the body from T lymphocytes. And what we saw, and usually it's fludarabine is one of the 2 drugs used for that. If you have a high fludarabine area under the curve or a low fludarabine under the curve, your outcome is significantly different. This is in terms of leukemia-free survival. This is, if you look at the CD19 positive relapse after CAR T, If you have had a low fludarabine exposure, you have much more relapses than if you have a high fludarabine exposure. So also the lymphodepleting regimen is important for the outcome. This is our own study, and there's one other study from New York who confirms this. So I told our data, or some of our data on the infants, BCR-ABL-like, on asparaginase, ALL10 and MRD, ALL11 with Icaros, to 3 years of therapy with reduction of anthracyclines for the favorable subtypes. I showed you what we're doing now with the altogether, and I showed you some recent data on immunotherapies. And having said this, I want to close with showing the same slide I showed you earlier, and with a picture of the Prinses Maxima Center in Utrecht in the Netherlands. And I hope to see some of you very soon. Close by Utrecht is Amsterdam, and there we will have the site 2025 meeting in a month from now. Thanks for your attention.
And thank you very much, Dr. Rob Peters, for that excellent coverage of all the minute details that are required in the management of childhood ALL, and you have brought out so many, nuances about the treatment that I think a lot of us have learned many things new during this talk. So thank you very much. And one thing I can make out from this talk, and that was actually even mentioned by, the Dana-Farber group years back, that L-asparginase is a very, very important drug in the management of acute lymphoblastic leukemia. And now with the the problem with all the, you must have seen all the developing countries where the drug quality and this thing is at fault. I think one of the reasons is we have to make sure that the drug is of good quality and good this thing, and continuously be on the lookout and do the levels and the activity of asparginase to make sure that the drug that we are getting is up to the mark, because so many lives are at stake. And I think we are doing that now all more and more, especially in India. But I hope all others outside also must have started looking at the levels and the activity of asparginase during treatment. But thank you very much, and over to you, Manas, for further deliberations.
Yeah, so we'll just take the questions that are there in the chat box. Dr. Peters, if you have some time, is it okay if we just discuss a few questions?
Of course, of course.
Yeah.
Go ahead.
So the first one is by Dr. Kriti Hegde, who has asked what would be the approach to treat non-MLL infant ALL without any high-risk features, especially in a setting where delivering interferon could be challenging? Or do they benefit with more cytarabine, which tilts risk versus benefit?
Yeah, we now use the interval protocol only for KMT2A rearranged cases and not for KMT2A germline cases. So we treat these infants according to our, let's say, current altogether protocol. So the advice is to use your standard ALL protocol for KMT2A germline cases, infants. Yeah.
Thank you. And on that note, I would just also like to say that even the St. Jude and the blinatumomab humanitarian access program has now kind of included infant ALL with KMT2A rearranged patients for the access of free blinatumomab. So that also has, will help some of these patients in developing countries where this program is running actively. The next question is by Dr. Preetham, who wants to know, is there any guideline on PEG asparaginase dose titration if the trough activity is subtherapeutic?
Well, the dose recommendation in our protocol, we now use 1500 units per square meter as fixed dose, but this is because we are doing a large study on the prognostic relevance of the drug levels, the asparaginase activity levels. If I would start a new protocol tomorrow, I would advise a loading dose perhaps of 1000 or 1500 as first dose, and thereafter you can go down to 500 units per square meter. And if you have the availability of drug monitoring, you can simply individualize the dose by measuring the drug levels in the blood. And the measuring the asparaginase activity levels is very cheap compared to the drug itself. So we always advise start therapeutic drug monitoring. Let a laboratory help you with that. It's not very difficult. It's just an ELISA reader that you need for it and some reagentia. But it's worthwhile to invest in that.
So if it is supratherapeutic, we can go down on doses from 1500 to 1000 to 500.
Yes, and 500 is definitely enough to get good activity levels for 2 weeks if you use Oncaspar. And of course, for native E. coli, it's different. But for Oncaspar, 500 units per square meter after a loading dose of 1500 or 1000, 500 units per square meter is enough.
What would be the frequency of asparaginase? Yes.
Just since in that same connection, that's okay for if it's low to go high. What do you all do if there's no activity or inactivity of asparaginase, like you showed both the places, not those who are silent inactivators, basically, or those who have no activity there because of allergic reactions or because of this thing? Do you all change the drug, or Erwinaze is also not possible to be given? And what do you all do in those patients that you have no activity of asparaginase, maybe because of silent inactivation?
Yeah, if you have silent inactivation of Oncaspar, it doesn't make sense to use native E. coli asparaginase because it will also be inactivated, with one exception. Some patients develop antibodies to the PEG moiety and not to the asparaginase moiety. And if you are allergic to the PEG moiety, then you can try, let's say, non-pegylated asparaginase. And if you do this for silent inactivation, also your patient is not at risk because you will not have anaphylactic reactions then. So you can try it, but measure then the activity. And usually you will not see any activity also with native coli, but in some patients we see that the native coli asparaginase is then okay, whereas the Oncaspar was not okay because of the allergic reactions to the PEG moiety. But this is an exception.
But if it's not because of PEG and it is just inactivation, do you all have a strategy of changing to any other? Because in your protocol, I think asparaginase is a very, very important drug,
Yeah. So so there's no good alternative if if you're allergic to the asparaginase moiety, you will also be allergic to native E. coli asparaginase, and there is no good alternative. If Erwinia asparaginase is not available, then there is no alternative, and we don't. We luckily have Erwinia asparaginase available, but if it's not available, then you have to think of other drugs instead of that. And it depends on your backbone of chemotherapy, what you already use. For instance, if your protocol is low in anthracyclines, then you may consider replacing the missing asparaginases by anthracyclines, but this is very individually depicted.
Thank you. Sorry, Manas.
No, that was very important, sir, and very practical too. The next one is about frequency of asparaginase monitoring if you're not in a clinical trial. So how frequent would you recommend? Because, now asparaginase activity is commercially available even in India. So some people might want to do it out of trial.
Yeah. We use a top level, so peak level after the 1 hour after the infusion, and then a drug level after 1 week and after 2 weeks, and then you give your new Oncaspar dose after 2 weeks. And the most important one is the trough level after 2 weeks, because upon that you can change your next dose. So this is how we do it. Yeah.
So out of all the 3 doses that you mentioned, you feel the most important is just before the next dose.
Yeah, that is the
Okay.
easiest to judge, yeah. But those patients that are, let's say, 0 after 2 weeks are already very low after 1 week also.
Okay. And suppose, on that note only, if suppose you're trying to look at the drug quality, so, we have got so many asparaginases and we want to look at the drug quality, would doing the 1 hour would be better than looking at what the 14 days would be? Would that 1 hour have a role?
If you have doubts about the quality of your product, I would definitely take the peak level. Well, if the peak level is very low, then you already know that your drug is not active. And if you have doubts about the quality, I would not wait for 2 weeks. I would also do the measurement after 1 week, and then and this will tell you already whether the drug activity is okay or not. And we have
Sure.
published, I'm thinking, I'm not sure which paper it is because we published a lot of papers on space age. We have a paper on how often you need to measure the activity levels with the levels which are, let's say, normal then. It was quite a recent paper, I think 2 years ago or so.
Sure. Dr. Preetham also has another question. We have found delayed clearance, longer half-life of one or two peg asparaginase biogenerics, 21 to 25 days. Should spacing the dose of asparaginase doses by 21 days instead of conventional 14 days be practiced in such circumstances?
Yes, that's possible. The cal asparagase, what is used in the United States. The United States don't use Oncaspar anymore, but the cal asparaginase. Both products are from Servier, but the product that is used in the US has a longer half-life, and then once every 21 days is enough to do it. And with the Oncaspar, most patients, well, once every 2 weeks is the regular schedule, but we see also patients there that have very high levels after 2 weeks, and you can even postpone then the new dose. But yeah, definitely if you have your longer half-life, then you can also use a schedule once every 3 weeks. It is all about how long your asparagine is depleted, and that's actually what counts.
That's re that's really personalized medicine, I think,
Yeah,
for
it
ALL.
is. Yeah, it is.
Yeah.
It is.
Yeah.
It is.
Yeah. So Dr. Bansal wants to know, is there a role of asparaginase monitoring at all? If you don't have Erwinia, what would why are we really monitoring?
Well, I think it is because why would you give a drug if it's inactive? And we know that if you can't complete your full asparaginase schedule, your outcome is worse. So then you can go for another replacement by a completely different chemotherapeutic drug. And yeah,
You have to
so
have an alternate strategy in such a situation
yeah,
as
of
to
course,
what you would do if, yeah.
yeah, yeah.
What about role of transplant in high-risk KMT2A rearranged infant ALL? If you don't have blinatumomab access, as most centers don't have that in India, what would you do?
Yeah, if you think of the slide that I showed with the medium risk patients and the high risk patients, so the medium risk patients have a KMT2A rearrangement, but not an age below 6 months and not a very high cell count. We have published this that a stem cell transplant is not of benefit for these patients. But for the high risk patients, a transplant is of benefit, and also in our current Interfund 21 protocol, we transplant these cases, also after blina.
So there is a definite role for transplant in infant ALL, especially the very high risk ones.
Yes, exactly. Yes, exactly. Yeah.
Yeah. Dr. Sandeep wants to know in intermediate risk, high risk ALL, in the ALL Together protocol, you have intensified treatment by inotuzumab and not blina. What is the rationale behind that?
The rationale was quite simple because the BFM group wanted to use a randomization with blinatumomab. The CUG was doing the study with blinatumomab that I already showed you, and we said, well, we don't need a third study, so let us then randomize inotuzumab in these patients, and the study is ongoing. So we simply choose inotuzumab because the two other study groups already studied blinatumomab.
Can we keep the remaining peg asparaginase stored in a fridge and use it after 2 weeks? That's Dr. Ravi Joshi asking.
Yeah, that's a good question. I don't know. I don't know. Send me an email and I will forward it to to our pharmacist. They may know. I think not, but I'm not sure. I have to ask them.
Off the record, sir, for you. We
Sorry?
off the record, I told the company tells us we cannot keep it, but we
No.
do routinely keep it and use it without any problem. So most of the centers in India do keep it and use it
Okay.
later.
And did you do you then measure activity levels?
We have done, and
Okay.
keep it in the refrigerator. So, you know,
Okay, good. I didn't know that. Oh, that's interesting data.
that's in India. That's the cost effectiveness.
Yes, yes.
Can,
Oh, well, if you have those data, that's perfect, of course, then. Yeah, good.
So even in private setup, where a person purchases a bottle of peg asparaginase, and he is paid for the bottle and
Yeah.
paid for the vial, and if
Yeah.
only say 1/4 or half of it is used, we save the remaining for the
Yeah.
second dose, which comes 14 days later. And again, it is not really recommended by the company. We have just one last question. In this protocol, total number of doses of peg asparaginase given is Dr. Deepa wants to know, because I think, the number of doses are just too many as compared to
Yeah.
what we use in India. So I think she just wants a comment on the number of doses of PEG.
Yeah. Yeah. Well, the number of doses that I showed you were in the studies that we used that high number. Now we use much less doses depending on your risk group. That's true. Yeah. So we started with these doses in the ALL10 and ALL11 based upon the Dana-Farber schedule, but I agree that the number of doses is far too high. So we have also reduced this in the altogether group. Yes.
So the number is somewhere around 14 doses or 16 doses, something
No,
like
no,
that.
it's lower. It's lower. It's around by heart. It is 5 doses in the intermediate risk low, and I think 9 doses in the intermediate risk high. But I have to check that. This is by heart, but it's
Okay.
definitely not around 15 or 17. No.
Sure. Sure. Thank you so much for answering all these questions and for a fantastic talk on ALL. Really listening from the horse's mouth of all the acute lymphoblastic leukemia experience that you have had in all these years. It was really heartening, and um, um, it was a fantastic lecture, and we had more than 115 participants for the session. And I'll now request Dr. Banavli to just give his closing remarks.
No, thank you. Everything has been said and done, but a lot of things to learn, and every day we learn something new. But some minor points also make a big difference. So I think you have brought out so many minor points of nuances of treating children with ALL. We are really thankful to you for taking out time and being part of this. And this is very important because this is the childhood cancer month. So for us, it is also important in that respect. So I think we have had you at the right time. But again, it's a personal and request from the whole pediatric hemong community that sometime we have you here physically also, so that we can interact with you more during the talk and after the talks also. So we hope that sometime in the future you get some time to do visit us and visit our centers, interact with our community, which is a small but a growing community and a very young and dynamic community. So I think thank you once again, and hope to see you during the SIOP meetings at least. Thank
Okay.
you, sir.
I
And
will be there. I will be
yeah,
there.
no, so we hope, man, from our side, you will be there. Hopefully, we'll also be there. But definitely, we'll make it a point to do meet you when we attend the meeting. So thank you
Okay.
once again, and thank you all the attendees on being part of this very, very important. I think those who have missed, we can pass on the link for the recorded
We-
lecture. And thank you once again, Manas, and the whole your team that really takes care of this meeting. over the last 2 years. Thank you very much.
Thank you so much,
Okay.
Dr. Rob Peters, and good luck with your tenure in CEOP. And, India is really wanting to work more and more with CEOP and, get all your agendas through so that, we can do the best for our patients here in India as well. Thank you so much.
Okay, thank you. Okay, bye-bye. Thank you, my pleasure.
Bye. Thank you so much.
Okay, bye-bye.